spring semester I came here. I came here to play football. Played a year and a half of that. I decided I'm not going to play my next year of eligibility. Just kind of done with that.
Sorry, I couldn't hear. Why are you not playing?
I'm tired of it, to be honest
You
with
don't want
you.
to?
Yeah, just
Yeah.
been doing it for a long time. Just don't really like it as much as I used to. So I'm a philosophy minor. I'm a sociology major, and I was originally a philosophy major, but honestly, I was just closer to being done with my sociology degree. I had more classes and stuff taken, so I just kind of flipped them. But yeah, that's me. Oh wait, we gotta go. Oh, was it recording?
Mm-hmm.
Cool. All right. So as I said, Trey Zimmerman. I did my presentation on. My presentation is going to be about an ethical critique of sex change procedures through biomedical ethics. The issue of sex reassignment surgeries, also known as gender-affirming procedures, has become one of the most debated topics in recent years, especially in the field of biomedical ethics. These interventions, which include hormone therapies and surgeries, are increasingly discussed in both medical literature and in public discourse. Despite their growing visibility, they remain deeply controversial. One of the key considerations behind these procedures involves the condition of gender dysphoria, which is defined by the Mayo Clinic as an emotional distress experience when a person's gender identity differs from the sex they were assigned with at birth. These individuals are already made out to be outcasts in our society. They often feel left out, they feel judged, and sometimes in a pretty ruthless manner. For many, medical transitions are seen as a way to bring their external body in line with their internal identity, offering relief and psychological well-being. But ethically, the answer is pretty far from simple. These procedures raise complex questions about autonomy and informed consent, beneficence, non-maleficence, and justice and access to care. As the AMA Journal of Ethics outlines, these 4 principles are the backbone of ethical decision-making in medicine and must be taken seriously and seriously considered when evaluating gender-affirming care. With the increasing demand for these procedures, there's an urgent need to evaluate how we balance personal choice with medical responsibility. This becomes especially crucial when treating minors or vulnerable populations, where long-term outcomes and irreversible effects must be weighed carefully. To add more depth to this analysis, this presentation leaves a method also called phenomenology, defined by the Stanford Encyclopedia of Philosophy as the study of first-person lived experience, which we all know from our book. Incorporating real testimonies and personal narratives allows for a fuller picture of gender dysphoria and medical transition, which helps us understand not just what these procedures are, but what they mean to the people living through them. I will explore essential questions like, do gender-affirming procedures uphold true consent and rational autonomy, or do they demand stronger ethical safeguards? Can the principle of doing good override the risk of causing harm? How can we ensure fair and equal access to these procedures, especially for marginalized communities? By analyzing these questions through both ethical frameworks and lived experiences, the study aimed to strike a balance between compassion and caution, protecting both personal identity and medical integrity. We'll start with autonomy and informed consent. As you guys know, autonomy is a person's right to make informed choices about their body and their life. In gender-affirming surgeries, autonomy is especially important because the procedures involve identity, body, and long-term outcomes. But autonomy isn't always absolute, as we've discovered this semester so far. Not all decisions are made from a place of clear-headed thinking. Emotional vulnerability, like gender dysphoria, can cloud judgment. Stephen B. Levine is an expert in this area, points out how complex this can be. Are the choices fully informed, or are they driven by distress? So informed consent is defined as a process, not just a signature, not just a concept. True informed consent means knowing all the risks, options, and consequences. In gender transitions, this can be especially hard. Emotions are high, stakes are high, and the outcomes can be often permanent. So where's the ethical tension? We want to respect autonomy, but we also have a duty to protect people, especially if they're struggling mentally or emotionally. What about minors? Can teens truly grasp the consequences of these medical transitions? These are core questions. When is a person truly capable of giving informed consent? What safeguards are there in place? Which brings me to beneficence versus non-maleficence. Beneficence, as we know, is doing good, improving health and well-being, while non-maleficence is not causing harm. Are quoted in our book by Beauchamp, one ought not to inflict evil or harm. In gender-affirming care, these two principles can kind of conflict each other. So the case for beneficence, many patients report improved mental health. There's lower rates of depression and suicidal ideology, and some say surgeries help them live more truthfully to their identity. But harm is real and it's possible. These are major surgeries. They're permanent, invasive, and high risk. Risks include pain, infection, complications, sexual dysfunction, lifelong hormone use without long-term effects, and psychological regret. So my argument is sometimes that medical providers rush to intervene without a deeper psychological evaluation. Just because a person is suffering doesn't mean that surgery is the answer. We need caution, not just compassion. Quoting the AMA Journal of Ethics, providers must balance immediate distress with long-term health outcomes. Support for transgender people is essential, but we must ensure that their choices are truly informed, carefully considered, and not harmful in the long run. Until we have more research and better mental health protocols, these procedures may not consistently meet the ethical bar. So then I bring up phenomenology. To fully understand the ethics of sex change procedures, we need more than just clinical data and policy debates. We need to consider real life lived experiences. This is where phenomenology becomes important. A philosophical method that highlights first-person experiences as a source of knowledge. Through a phenomenological lens, we gain insight to the emotional, psychological, and social realities of individuals with gender dysphoria. These personal narratives help us better understand what autonomy and informed consent actually look like in real-life situations. Importantly, using phenomenology doesn't mean that we have to support or reject these procedures. It simply helps us understand how people experience them. By including these perspectives, our ethical evaluations become grounded in real human lives, not just abstract principles. So now I'll give you guys two stories. I'll give you guys a positive one and a negative one. So Avery is a transgender girl who began her transition at a young age. With the support of her family, she socially transitioned and later started puberty blockers that delay male puberty. According to her mother, Avery is now happy, healthy, smart, funny, and thriving, and is progressing well with her transition. This example highlights how early and supportive gender-affirming care can indeed lead to positive outcomes for transgender individuals. Now for a more negative story. Kiara Bell is a British woman who began transitioning from female to male at age 16, receiving puberty blockers, testosterone, and double mastectomy. As she matured, Kiara realized her gender dysphoria was linked to underlying issues like depression and anxiety, not a mismatch between her gender identity and biological sex. She began detransitioning at age 20, experiencing profound regret and facing irreversible physical changes like infertility and a deepened voice. Kiara's experience underscores the importance of thorough psychological evaluation and informed consent in gender-affirming care. I'll move into the ethics of medicalization and identity. So as sex change procedures become more socially accepted, they also become more medicalized, meaning they're increasingly framed as a clinical solution to these identity struggles. Medicalization can feel affirming for some, but it also risks reducing complex identity questions to medical problems. This framing may unintentionally reinforce a binary view that gender doesn't reflect the full range of human experience. It raises ethical concerns, especially for young people who might feel pressure to pursue irreversible treatments to validate their identities. It forces us to ask, is changing the body the best ethical solution to identity distress, or is it a medical response to deeper social and psychological issues? While it's true that many transgender individuals find medical interventions life-saving and affirming, that doesn't erase the ethical tension. From that perspective, medicalization can be empowering, giving people the right to define their bodies and identities with professional help. But even in the most supportive scenarios, problems still remain. Those who choose not to transition or who later regret it can be marginalized and left out of the conversation. This is exactly why phenomenology is so important. It helps us to understand all lived experiences, not just the ones that confirm dominant narratives. So ultimately, it challenges us to ask whether current gender care is truly patient-centered or whether it reflects deeper institutional and cultural biases about what gender is supposed to be. Which brings me to justice and access to care. So justice in biomedical ethics is about fair distribution of resources and equitable access to medical treatment. When it comes to sex change procedures, justice raises difficult questions. Who gets the access? Should these be subsidized in healthcare systems? Some see denial of gender-affirming care as discriminatory. Others argue that prioritizing such care over basic needs in an underfunded system is already unjust in and of itself. Key problem, framing access as a justice issue often assumes that the procedures are already ethically legitimate. But if the critics of these procedures are unclear and contested, then expanding access without deeper evaluation could cause more harm than good. Justice doesn't mean giving people what they ask for. It also means ensuring that what's given is beneficial, ethically sound, and in their long-term best interest. Advocates argue that barriers like financial barriers, geographic or age-based, cause real psychological harm. People in marginalized communities have even steeper barriers, leading to alienation and deepened distress. These testimonies are powerful, and they must be considered seriously in the ethical debate. However, ethics is not just about compassion, as I mentioned earlier. It's also about caution. Especially when young or vulnerable people are involved, procedures have permanent effects, and long-term outcomes are still unknown. In those cases, justice might actually demand a pause, not faster access. The ethics of sex change procedures is one of the most intense and ongoing debates in modern medicine. It touches on deep questions about identity, autonomy, and the purpose of medicine. This study argued that when offered in kindness, even when offered in kindness, these procedures have unsettled ethical foundations, especially long-term. Autonomy must be informed, rational, and done in good faith, not a green light for irreversible choices to be made under distress. Beneficence and non-maleficence, healthcare should help, not harm. When long-term data is lacking or negative, especially in young people, these principles call for restraint. Justice goes beyond access. It asks whether we should be granting access at all, especially if harm may result. Phenomenology gives voice to lived experience, crucial for grounding our ethical discussions in real human stories. But pain and alienation, when real and valid, don't automatically justify every medical response. Medicine must weigh emotion with evidence and identity with impact. We must protect individuals, especially the vulnerable, from well-intended but potentially harmful moral decisions. Are we truly doing what's best for people or just what feels compassionate in the moment? Ethicists and physicians must be willing to face hard questions, resist ideological pressure, and keep compassion and caution in balance. Only then we can begin to find a truly honest and just path for this medical and ethical minefield. That's it. Short.